So today I think, thanks to Sunny for a very nice, comprehensive and succinct lecture on some of the data and the evidence that we have currently in CRS and HIPEC in ovarian cancer. And I'm going to switch track a little bit and I think go through a bit of what we have gone through in Singapore and our experience over the last, I think about 30 years now, that we've been doing CRS and HIPEC. So actually, it very first began in 2001, where we did our first case. Our then director of NCCS, Professor Chia, did a CRS and HIPEC for a patient with pseudomyxoma peritoni from Indonesia. And I remember the patient came to him in the clinic and asked for the sugar baker procedure. So Professor Su, not being one to say no to the patient, printed out, I think, like 100 copies of Sugar Baker's instructions on how to do the CRS and HIPEC. Went through the whole procedure. It took about 16 hours, I think. We borrowed the single roller pump perfusion from the CTS team, and we successfully completed the very first one. And our anesthetist, you can see on the right, Dr. Wong and Dr, has been instrumental. He's been with us since the very first CRS and HIPEC. And anybody who has come to Singapore will have seen him. He's still doing our CRS and HIPEC many years on today. So like I said, we've been doing it since 2021. 2001. Which is almost 24 years going strong. But we've had a lot of challenges along the way, setting up the program. And even after we've set up the program, there's still many challenges that we're experiencing. So I know you guys are sort of like maybe just starting in getting to do CRS and HIPEC. So maybe this might be helpful to you on how we started this program. So the challenges really can be broken down into three categories: conceptual or philosophical, the resources that we have, and lastly, mentoring and proctoring in this field. And when we look at conceptual challenges, again, we can break them down into various factors. So there is a perception that there's very little evidence for CRS and HIPEC, although we now have more data in all disease subtypes, and I think you can see that from Sunny's presentation earlier. There also is a misconception that the morbidity and mortality rates are very high after CRS and HIPEC, and that quality of life can be very poor. There's also not just an issue of cost, but whether it's cost effective. And I think this is something that perhaps we also have to answer locally in each of our countries. Lastly, awareness is still very poor when it comes to the available options for peritoneal surface malignancies, especially in a lot of our colleagues who are perhaps not familiar with peritoneal surface disease. So I'll touch a little bit more on some of these factors in detail now. And as I said, I think Sunny did quite a comprehensive summary of the data that is out there. But when we really first started out, we also had to publish our own data. And it's very interesting. And I think at the start, when we first started doing CRS and HIPEC for ovarian, we weren't really getting the upfront ovarian cancer cases. Although now with the Vendrio trial, we are starting to see more and more patients in this setting. So at that point in time, we did a lot of recurring cases because at that time there was no data, very little data for CRS and HIPEC. So we were being sent the cases in which our medical oncologists had very, very little options left. So usually these patients had maybe like 2 to 3 lines of chemotherapy already, and the medical oncologists were scratching their heads at what to do with these patients. So they said, okay, now we have nothing left. We'll give it to the surgeons and see what they can do. So you have to keep in mind that this data, this subgroup of patients that we were doing at that point in time was a very biased selected group. And probably in this day and age, you look at it and say, oh, we would not select these patients for CRS and HIPEC. But unfortunately, those were the cases that we were getting back then. So you can see over 8 years, we did about 41 patients. And despite that, I think, getting the poor patients, we kind of had decent results. Our median overall survival was 42.8 months and 5-year overall survival 49.3. And you can see from the 5-year disease-free survival that many of them recurred. And this is what I think you would see with Sunny's data that you presented just now. So a lot of them are alive. They had good overall survival, but a lot of them were alive with disease. And because of this, a lot of them also subsequently had repeat CRS and HIPEC in our settings. So going on to talk a little bit about mortality and morbidity, and you'll see in this very interesting paper written out of the US in 2019, that they state here that the referral rates for CRS and HIPEC are low because of the misperception of high morbidity and mortality. And you can see in this paper that they they put down this table, right? And you can see that the 30-day mortality for CRS and HIPEC is not just comparable, but actually better than that of other major abdominal surgery. So we really shouldn't be very worried about mortality rates. How about morbidity rates? And you can see that in expert centers around the world that the morbidity rates really aren't that far off from other major abdominal surgeries. In fact, in our own center, we just recently published our updated results about 2 years ago. Our mortality rate is now almost negligible, and our major morbidity rate is only at 13%. And of course, it's very important to reduce the rate of complications because we have shown that complications are, as we know, associated with readmission rates, associated with poorer overall survival, as well as disease-free survival. So some of the, I guess, our own experience when we went through and some of the complications that we encountered along the way include intra-abdominal collections. So we were getting this quite commonly, and we realized that we were getting this because at the start, not only were we giving HIPEC, we were also doing EPIC, which is early post-operative intraperitoneal chemotherapy. And we were giving this because that was what Sugar Baker started off doing. So after the HIPEC surgery, for 5 days, every day in the ward, the patient would get some chemotherapy into the tummy. And because of this, it was difficult to drain it out because you can't completely drain it out as opposed to post-operatively. So we stopped EPIC after a while because there was no evidence for it. And we also kept the drain-ins for a lot longer. Some other reasons why patients would get collections more commonly is especially after if you do the HIPEC in a closed setting, you may not be able to completely drain all the chemotherapy out. So for that reason, some people do an open method where they reopen the abdomen again to make sure that everything is drained out completely. I sort of do a semi-closed method where I'm able to drain out the fluid after, and I'm also able to put my anti-adhesion barriers in after the CRS and HIPEC. So pleural effusions was another problem that we had, and this we realized occurred more commonly after a CRS and HIPEC than if we were just doing a CRS alone, because when you strip the diaphragm and you give the HIPEC fluid tends to sometimes transverse through the diaphragm and into the pleural cavity. And so we weren't routinely putting chest tubes in then. And then we realized that our morbidity rates were very high because then all these patients will get a pleural effusion. And the minute you have to put a chest tube into the ward, that becomes at least a grade 3 morbidity. So because of that, we now routinely put in a chest tube once we strip the diaphragm and give HIPEC. The last thing, which I'll talk about a little bit more in detail later, is renal impairment. And this was really a big issue for us when we first started. I remember in 2009 when I went for one of the very early SOGI conferences. I think it was in Berlin, and I think at that time there were only about maybe 100 people in the audience because PSM wasn't a big deal back then. I asked the question if anybody else was having problem with renal impairment after giving cisplatin HIPEC. And I think all the Europeans and Americans looked at me and were like, nope, we don't have this problem. And I was thinking, okay, maybe this is a very Asian problem and we need to figure it out ourselves then. So then we went on to look at our own data. And so we had about 47 patients who had acute kidney injury. We realized that all of them had preoperative chemotherapy, and the median cisplatin dose at that time was 90 milligram per kg. A very high rate of 40.4% had AKI, 8.5% of them were grade 3 and grade 4, and 2 of them actually required long-term dialysis. And we noticed things like higher baseline creatinine, EGFR, if they had a lower pre-op albumin, and very interestingly also if they had a higher number of chemotherapy cycles before the surgery, and if there was a closer time between the surgery to the chemo, then these patients were at higher risk of developing AKI. So for a while, we had a lot of problems with this. And in fact, our oncologists stopped referring cases for CRS and HIPEC to us because their reasoning was that the minute the patients developed AKI, they were then unable to continue with their systemic chemotherapy after that. So they said, okay, if you don't solve this problem, we can't do this anymore. Right. So as a result of that, we dug around and then we came across a protocol developed by the MD Anderson team by Jordan Hayes, and they were doing HIPEC cisplatin in the pediatric population for kids with desmoplastic round cell tumor. And they were having the same problem because they were using HIPEC with cisplatin. So we used that protocol of giving sodium thiosulfate, which is started intraoperatively, half an hour after the cisplatin HIPEC starts, and then it continues for 24 hours after that. But we also added on our own protocol on how to select patients. So we have to make sure they're creatinine. We check their EGFR preoperatively. They all come in the day before to get hydration. And we have a very strict protocol on how much the urine output needs to be intraoperatively and postoperatively. And we write all the instructions there so that in the middle of the night, if the urine output drops, the house officers know how to correct and fluid challenge or whether they need to give furosemide. So very interestingly, in 2020, I think, maybe the Europeans started having the same problem, but they then published their paper about sodium thiosulfate and how it protects renal impairment following HIPEC with cisplatin. So that's it for about our complications. But another aspect to our service that we added on subsequently that does help us to improve outcomes is ERAS. Now, when we first started ERAS, we were kind of intimidated because it seemed kind of daunting to do ERAS for such a complex procedure. When you think about ERAS, you think about perhaps, maybe in the gynae setting, THPSO or the minimally invasive surgeries, or in our colorectal setting, we do it for the laparoscopic colorectal resection. So for our CRS and HIPEC, when there's so many moving parts and so much variability, it seemed a little bit challenging. But we did come up with one, and we do have quite a strict selection criteria for which patients can be put onto our ERAS protocol. And you can see that our protocol allows for some flexibility in terms of when we take out the NG tube, when we take out the drains, how long we keep rectal tubes in for, when do we give bowel prep. So it does allow for some flexibility. Now, we've just finished our pilot study and we're waiting to write up the data, but already we have seen that there's an improvement in the length of stay for many of our patients. So now that we've finished that pilot, we've also expanded our ERAS program to what we call SURPASS, which is a more comprehensive program. Now, this program also includes prehabilitation, where they get to see a physiotherapist prior to having the surgery. And they also are referred to our psychosocial oncologist to have a serious illness conversation to talk about any end-of-life issues. Okay, so I'll go on to the next aspect, which is quality of life, which is, a lot of people think that, oh, if you go for a major surgery and a CRS and HIPEC, you're not actually going to come out much better for it, right? You're going to have a poorer quality of life. And so why should we undergo such a major surgery? So again, we had to show our own data, and we had to show an improvement in quality of life of our patients after CRS and HIPEC. So this is what we've shown, and it's corroborated across many international trials now that the quality of life, of course, decreases immediately after surgery as to be expected, but it comes back to baseline by about 6 to 12 months. And when you compare this to patients undergoing palliative chemotherapy, actually most of our patients did a lot better. And in fact, the component in which the scores improved the most were actually the emotional scores. And I think the reason is this being that by the time a lot of the patients came to us, they had probably seen many, many surgeons and doctors who had told them, there's nothing I can do for you. This is the end of life. Maybe go for palliative chemotherapy or maybe best supportive care. And then suddenly they read up or somebody sends them to see us and they realize, oh, it's not the end. There's something I can do, right? And then they find like, oh, there's a new lease on life. So once they finish the surgery and the chemotherapy, that sort of improves their emotional scores. And that really, I think, is what helped bump up the quality of life scores overall. Another problem that we had locally was thinking about cost. And this is something that we had to do in our own local setting because no matter how many papers are published out there about cost, our government will come back to us and say, oh, the setting is not the same because the government structure is different, how you subsidize the healthcare is different. So we then had to look at it in our own setting. And we compared patients undergoing CRS and HIPEC to patients undergoing palliative chemotherapy. And we did show that it was cost effective because it was less than Singapore's 1 GDP per capita. Okay. Now I'm going to switch a little bit and talk about PIPAC, which I think Sunny didn't really talk about. I don't have a lot of time to go through it, but I just wanted to touch on it a little bit here because it's one of the newer techniques that we're currently being used, mostly in a palliative setting. So you can see here that PIPAC, which started maybe about 10 years ago, or first started being used about 10 years ago, is really a novel method of us being able to introduce chemotherapy into the abdomen at high pressures. It's a method of delivery. It's not the drug because the drug can change, but it's really doing a diagnostic laparoscopy to assess the extent of the disease, to drain the ascites. We can get biopsies, and because we can get biopsies and we can see the disease, We can visually see each time when we go in whether the patient is responding to our treatment, and not only visually, but also histologically, because we send the specimens off, and we look at what we call a peritoneal regression grading score. And we can tell that the patients are responding to the PIPAC. And then once we score all these things and we take the biopsy, we put a pen in. This is a high pressure, this is a pen, a specialized pen that is connected to a high pressure injector. And this chemotherapy is then pumped into the abdomen for half an hour. So you can see this is an example of what the pipette looks like. This is the pen, and this is the chemotherapy that is coming out, that is being aerosolized within the abdomen, and you will see this snowstorm effect. And this is for about 5 minutes, you'll get this effect, and then we leave the chemotherapy in there for the next half an hour. So just as a summary about CRS and HIPEC and PIPAC, and in this very nice paper published in Nature, you can see, and I've highlighted in the curative intent, and for the ovarian setting here, what the recommendation is of course systemic chemotherapy plus perhaps a CRS and HIPEC. It's just a matter of timing. Here again, you can see CRS and HIPEC with systemic chemotherapy and perhaps some IP chemotherapy thrown in as well. On the right side here, you will see that in the palliative intent, or perhaps now people are starting to look at PIPAC also in a neoadjuvant setting. For the ovarian cases, of course, after first-line systemic chemotherapy, after you start second or third line, if there's no response, perhaps at that point in time, you can consider putting some PIPAC in. Again, in this draft out of the ISSPP group, you will see that in the upfront setting, PIPAC, again, here is still under study conditions, but to be considered for unresectable diseases. And there are a lot of randomized trials ongoing and being planned for PIPAC in these conditions. So you will see here that some of the possible indications include PIPAC in the third line situation. For second line platinum resistant recurrent cases, people are now starting also to look at it in a neoadjuvant setting when you think it's a non-resectable case. Perhaps when patients cannot tolerate systemic chemotherapy anymore, when they are deteriorating QOL, because it has also been shown that PIPAC actually improves the quality of life of patients. And also very interestingly, it can also control the ascites. So just for PIPAC alone, I think in this systemic review published in 2018 that looked at, you can see that there are no RCTs that were done at that point in time. But for ovarian, the tumor regression rate was about 69%, overall survival about 13.7 months, and a progression-free survival about 6 months. So again, keep in mind that this is in a palliative setting. So there are a lot of studies out now, a lot of them being done by Professor Somashekhar in Bangalore in India, looking at CRS and HIPEC after PIPAC in the advanced inoperable cases. We have also routine guidelines and rationales for when and why we give PIPAC for ovarian cancers. And also looking at it again in platinum-resistant cases in a recurrent setting. So this is just an example of, some pictures that he has shown of PIPAC. You can see from the first to the third, going from left to right, intraoperatively what it looks like. And also on the scans, you can see that the ascites has really improved quite a fair bit. So in Singapore, we are undergoing the same cycle as we did with HIPEC. We have just completed our safety and trial. And we're now starting to look at running a trial, looking at efficacy, again, having to look at quality of life, and again, having to look at costs in the Singapore context. So going on to the last bit on conceptual challenges, and this is quite interesting. I think when we looked in our Singapore context about, where the trends and the referrals for CRS and HIPEC were coming from, you realize that a lot of our patients were coming from our medical oncology colleagues and mostly within our institution. So awareness was really very low outside our sphere. And when we dug a little bit deeper, we realized that a lot of people were not referring to us, again, because of the misconception of the safety profile. A lot of them were even unaware that there were such treatment options available and that there was a center that was doing it. A lot of surgeons will just determine that, these cases are not suitable, instead of sending them to us to at least have an evaluation. And because we are at the end of the day a public institution, so sometimes there's a perception that waiting times are long, and of course sometimes patient refusal as well. So because of this, I think we then started on a bit of outreach program to various areas. Firstly, I'll show you to the public. So we started publishing a lot of articles featuring our patients who have gone through CRS and HIPEC and come out at the other end. So we published in multiple newspapers on our patients. We also gave public forums and talks about peritoneal surface disease malignancies. We then also outreach to our GPs, to let them know that this was available, because I think at that point in time when our GPs were going through medical school, perhaps this was not very well known then. So again, we gave GP talks. We also printed in the GP newspapers and articles about CRS and HIPEC. And lastly, of course, not forgetting the specialists, even within our hospital, who were not aware of the work that we were doing, and of course, the other tertiary hospitals. So going very quickly on to some of the challenges that we faced with resources, and again, we can break them down. So institutional operating theatre, I think in those surgeons that are here will know what a struggle it is to try and get operating theatre space. It's even harder when you're trying to get space for a case that will last at least 6 to 8 hours long. Intensive care facilities, of course, is something that you must have. But we've also realized that with time and experience that actually right now, as of this point in time, less than 1% of our patients actually require an ICU bed, and most of them go to the high dependency post-operatively. And lastly, like I mentioned, the reason of economics, not just at a national level, but also at an institutional level. That was something that we had to convince our senior management about. Human challenges, I think it's very, very important that we build a team around the patient. And I think we've been very fortunate over the last couple of years to build a very strong team of various subspecialists who are dedicated to looking after patients with peritoneal disease. So not just our medical oncologists, but also our anesthetists, our radiologists, and our nuclear medicine colleagues, our pathologists, as well as our nursing and paramedical team. Research is something that I think we also need to think about when you're starting a program. And it's not easy because you're trying to fight all these other fires, and sometimes research is the last thing on your mind. But I think when you're starting out, it's quite important to start collecting data, because when you do it right from the start and start out a good registry, there's a lot of headache later on trying to go back and try and recap some of this data that you're trying to sort of collect. So think about starting a registry and collecting your data very early on. Think about collecting quality of life data as you move along. And also think about, if you have any links to anyone doing, whether it's in your institution or outside, doing translational research, participating in clinical trials, again, either within your region or outside. And also thinking about innovation, because I think this is quite a new field and there's really a lot more that we can do in this space. Lastly, just talking about mentoring and proctoring, I think this is also something that is quite important, because this is a complex surgical procedure, and we need to be able to train the right way and attract the right talent. We've also shown that there's a learning curve, of course, to these sort of procedures, and that 50 cases were adequate for being familiar with the procedure and decreasing your surgical time. But the significant decrease actually really appeared after about 100 cases, where the rate in the serious morbidity really dropped. So C3 is when after the 100th case, you see that the serious complications really, really dropped after that. So how do we learn? I think, there are international groups out there that have a lot of educational initiatives going on. In the HIPEC space, we have the SOGI group, which has linked up with the ESSO group, and we run the European School of Peritoneal Surface Oncology. For PIPAC, we have the ISSPP group. So the ESPSO group, like I mentioned, runs this very comprehensive 2-year fellowship that requires you to spend time at a center, write papers, attend conferences and courses. Most of the training centers are within Europe, but Canada, Australia, ourselves in Singapore, and Turkey are the ones outside of Europe that runs this fellowship program. And this ESPSO fellowship program can be done concurrently with our own local NCC fellowship. ISSPP, like I mentioned just now, if you go onto their website, they run multiple courses for PIPAC throughout the year. You can go and see when the latest upcoming courses for PIPAC are. So every year we hold a Singhealth Peritoneal Surface Oncology workshop, and our conference is 2 yearly. So our conference is recognized by the SOGI group, and our workshop we run the ISSPP PIPAC program at the same time. So this was just our conference that we held and workshop that we held this year. We had a very nice gynae onc session with specialists from Olivier Glihen, who published the SHIPEC trial out of France, Professor Som Shaker, who does a lot of the Indian trials, and Professor Kim Byung-gi from Seoul. And so lastly, of course, networking, I think it's very important, when we go for all these conferences and congresses, because we're constantly learning. I'm constantly learning from all these world experts all over. And so it's important to get links because we are continually sharing the work that we're doing and learning from one another. Yeah, so this is our team that has gone to multiple conferences, and I would invite you all to join us. We have a conference coming up 26th to 28th September in Lyon, France. It's a very beautiful place. It's actually where I did my fellowship learning peritoneal surface malignancies. So I think the abstract date is still open up to June. And if you have the opportunity, please do join us then. Yeah, so happy to take any questions. Thank you.